Right, just one other consideration about the psychosocial stuff that I forgot to mention. It doesn't happen often, but it does happen, and it's something that's worth being aware of. And that is the relationship that happens, or the marriage that happens following a horrific injury of some description, only for the reason that the person can't leave the cripple. And so it's kind of, there's a, well, the relationship wasn't that great, but it would do, and now they've gone and got themselves all buggered up, and I can't dump them now. And that's the problem. And some people are trapped in relationships. You get these kind of weird little unfortunate things that can happen. Right, practical stuff. In terms of phantom limb, these are the considerations to have when looking at the phantom itself. Without a doubt, the single most important thing, and I can't emphasize how important this is whether remapping phenomena has occurred. What interests me is how many clinicians have absolutely no idea about remapping phenomena, and how many clients that I've worked with amputations, who, when I tell them about remapping phenomena, it's the first time anyone has ever explained it to them, even though they've got a 20-year history of amputation. And I find it extraordinary. Now, I meant to bring a picture to show you, but I left it back home. In the brain, there's a band that goes across the middle here. It's not really a band, it's just a section of the brain that's been marked out. The sensory cortex and the motor cortex. Sensory cortex is the part of the brain that processes all the feelies. The motor cortex is the part that outputs the movement, and that kind of stuff. Now, there's a brain map. See, different parts of the brain map different parts of the body. And if you look at it, the fingertips, for example, because we do a lot with our fingertips, have a huge number of cells dedicated to both senses and movement. So does the mouth and tongue, especially lips and tongue, because this is very complicated what we can do with this. We don't do very much with that little bit of skin there. There's not a lot happens really there. We don't need too many brain cells dedicated to it. So you're not ever going to learn Braille by using your elbow. It's going to be quite difficult to learn to do that. But you can learn Braille very quickly with a fingertip. It's extraordinary because there's so much brain power dedicated to those areas. Now, the way the brain is organized, if you look on the map, on the sensory map, on the sensory cortex, the hand and the face, neck, and upper shoulder are right next to each other in terms of where they're organized. The feet are right next to the genitals. They're just sandwiched next to each other. Now, remapping phenomena is very, very strange in how it occurs. And I'm hoping we can demonstrate this shortly. If I lose a limb, if you chop my left arm off, and please don't, but if you did, my brain and its organization of that limb hasn't been changed at that point in time. It's just set up as though there is a limb there. Now there isn't. There's no sensory data coming in. Yet there's a huge, great portion of the brain that's going, where's my data? Where's my data? Come on, give me data. And what tends to happen is in the reorganization of in neurology, is data starts leaking from other areas, predominantly for the hand, the face, neck, and upper shoulder. And so you start to get these weird sensations where sometimes if they're shaving, or they'll be shaving, they feel it in the corresponding place or corresponding limb. And that can be a bit weird. People don't normally talk about that because you're a bit weird, aren't you, really? Since your amputation, you're not quite the same anymore. Well, yes. So people learn to keep these things fairly private. Now, remapping doesn't always occur. My observation is this. When remapping occurs, the mirror box is 100% successful. When remapping hasn't occurred, it's less likely, it's not going to be, but it's less likely to be successful. I'm yet to find a single example where there is remapping and I haven't got a significant level of change in the phantom limb pain perception. It's hugely significant. Weird stuff happens. It's not a direct image. So what we might have is say if we stimulate the cheek here, it might correspond, say, to the fingertip. But if we stimulate it down here, it might be the wrist. You might get a part of the fingertip here, and the rest of the fingertip could be down here in terms of where the stimulation is. So it's not a direct match. You can't draw the hand to the face and neck. It doesn't work that way. But you can start to work out where it is. The way to do that is with the humble earbud. Use clean ones, always a bonus. What I tend to do, either put them in water and freeze them, or use dry ones and wet ones. So I have different stimuli, because the remapping is sensory specific. If I put cold on the cheek, it will feel cold in the corresponding part of the phantom. If I give a pain stimulus, it will pain. If I give a warm stimulus, it will be warm. If it's wet, it's wet. It's direct correlation. Not in all sensory modalities, but that's tends how it works, so it's direct. You want to pick a stimulus that the person is unfamiliar with. So a lot of people are used to touching the face with their fingers. Fingers are unlikely to elicit the phenomena too readily. People have never been stroked on the cheek, usually with a Q-tip, or a frozen Q-tip. So you're more likely to get it. And what I'll do is I'll just touch it very lightly at first in different areas and see what occurs. Sometimes you'll get people that will start to notice that as you're touching here, they feel it in the hand, but they have never noticed remapping phenomena before. So what I know is we cannot rely on the patient's reporting of remapping to tell us whether it's existent or not, because some people, they have never noticed it. But we can elicit it very, very quickly with a cotton bud. And what I'll start to do is I'll mark on the face. Don't use permanent marker. People don't like that. Use something that's easily washed off. A makeup type thing is easily washed off. You can mark on the face where the different parts are. And the weird thing is it's then consistent. So if you do it on another day, if you photograph the map on the face and bring them back another day, it'll be the same. Okay, so it becomes a fixed thing. With the remapping of the feet to the genitals, this is the one most people never discuss because it's all a bit awkward, a bit embarrassing. Somebody emailed me yesterday to say, yep, interested in what you say there. He said, I don't orgasm in my foot, in the phantom foot, which is very common. But he said, whenever I urinate, it's like I'm feeling it here, but I'm also feeling it in the phantom. So any sort of sensory stimulation in the genital area tends to be felt in the phantom as well. Remapping is most common in an upper limb amputation. It is less common in a lower limb amputation. And again, remapping is a very, very good predictor as to whether the mirror box will be successful. Here's the weird thing that happens with phantom feet when remapping has occurred to the genitals, and I have to tell you, I do not draw a map with a Q-tip on patients who have got a leg amputation. Okay, there's just something about that I say is outside of my job description. But people will report this. On sexual arousal, not only do they feel the sensations in the phantom, but the phantom itself can change dimensions for obvious reasons. When things engorge and enlarge, you can get a corresponding enlargement of the phantom itself. Not always, but it does happen. What else was I going to say on that? That's it, really. Going to come back to remapping in a second because there's a reason I draw it out, which I'll explain. Now, phantom image, really, really important. Three main variables. There are others. These are the three most common. When they look at the phantom, close your eyes and tell me what the phantom looks like. That's what I'll say. Close your eyes and tell me what it looks like. Well, it hurts. Now, this is important. I will say, I didn't ask you how it feels. Okay. It's rude, it's abrupt, it's interruptive, okay? Because people in pain are constantly tuning into how it feels. I want visual representation, I want visual cortex information. I want to know how the phantom looks, that's the detail. For some people, they have never considered this before because no one's ever asked them. Everyone asks, how does it feel? So, close your eyes, take a look at the phantom. What does it look like? I mean, is it normal? Is it damaged? What is it? It hurts. Didn't ask you how it feels. Now I want you to have a look. Look with your mental vision, your eyes. What does it look like? And you have to sometimes be quite firm with people with this. Most people, I've never had anyone that couldn't do that, by the way. I've never had anyone that says, oh, I'm not very good at visualizing. They can all do it if you tell them. Three most common things. It's normal. So it looks just like that would, obviously in a mental image representation. It's traumatized. The weird thing is the traumatization of a phantom is nearly always at the point of impact, at the point of initial injury, at the point where their body recognizes, oh shit, that's bad. Something really serious has just happened. If you ever hurt yourself, you always know when it's really serious compared to, okay, that's just really, really unpleasant. The body kind of knows the difference most of the time. And the other thing I want to know is the limb contracted? The single most common form of pain in the phantom is not through a traumatized phantom. So they're looking at a bloody mess with bones sticking out. They're not. Most of the time it's contracted. Now, if we just change subject for a second, if you think about people who've had a stroke, so part of the brain has been damaged, usually in the motor cortex, often the sensory cortex, and they're paralyzed down the opposite side of the body. Classic scenario. Where there's no mobility, because there's no output signal, the limb can start to contract. It's just a biological process in the ligaments, tendons, and muscles. Things start to get tight. What happens is the hand will come round, this starts to get tight, it comes up, and often it ends up contracted like so. And then we see physiotherapists doing their best to try and stretch it back out again. Now, prevention is better than cure for real contractures in paralyzed limbs. Nothing's happened to the limb. Okay, nothing's happened to the limb. The limb is fine. What's happened is in the brain, because the brain has changed. It's changed its mapping and stuff. So the limb is now doing its natural thing. If we remove a limb and there's a phantom, weirdly, because there's no sensory data coming in, and we get the remapping, the phantom starts to contract. And one of the most common things you find with a contracture or a phantom pain is actually contracture pain that they're experiencing. Again, most clinicians and most patients have no idea about that until I've mentioned it to them. So this tells me that the awareness of this is quite low. In talking to the university research team, they all know this. And I'm thinking, okay, there's a bit of a disparity in the information flow here between universities and clinicians. Now, so what we'd be doing for this is giving pain relief isn't going to really be that effective. Here we have a limb that doesn't exist, that is contracted. The brain is now interpreting that as a pain, and it's taking data from the face. Not always, but often. In order to work with that, if I use the mirror box and they look in the mirror, their kinesthetic representation of the phantom will not match the visual illusion that's being created. Now remember, we have the kinesthetic representation and visual representation. The mirror box will not work in the majority of those cases. So what we need to do is to move the phantom into a logical position in order for them to use the mirror box to get the reflection. Otherwise, their brain goes, yeah, I can see it's a mirror, it's a reflection. I look in the bathroom mirror every day. It's up there. Now, there's ways that we can start to work with that. I also want to know the position and the location. I work with a test pilot. That is a dangerous job and a half. Well, it's never been flown before, but we want you to take it up and see if you can break the sound barrier, that kind of thing. And this guy was a test pilot, and the plane he was in didn't stay up in the sky for very long. And the level of injury in this individual was absolutely extraordinary. I mean, I've never seen a man with that level of physical injuries on the body from 2 or 3 years previously who was still alive and had a sense of humor. Now, he was brought to me by his officers, his senior officers, and so I had a whole contingency of top brass people, all with the full uniform. They're kind of, well, kind of. And so this guy's horrendously disfigured. He's lost the arm here, I don't know if you see what lung on that side. It was extraordinary. One of his legs is missing. He's got horrific facial deformities and injuries, and a lot of burns and scars like I've never seen. I mean, just extraordinary. Now, his arm was like that, the phantom. Okay, his normal arm, which was still working, scarred and burned, was here, but the phantom is stuck behind his back, and that's why he can't sleep at night. That's the pain he's got. And the pain he described was exactly correct for somebody who's got an arm twisted behind their back 24 hours a day. So my job, before I can do the mirror box work, is to reposition the phantom. That took hours. And I'm going to demonstrate, if I may. Carl, can I borrow you for how we do this? I'm not going to do a full thing because it can take forever. Or it certainly feels like forever.
Not for you.
No, that's for you. Yeah, quite right. So if we just imagine it's your left arm that's missing, for example, and that's behind your back. I don't know how well this is going to work, actually, but for demo. So what I would get him to do is, so he doesn't have anything this side. This is the existing limb. I will get him to make a mirror image of the phantom using this one. So you might need to stand up, actually. That might be easier. Right, so now if you turn around, so now he's now giving me direct visual representation of what the phantom looks like. Because obviously, even though he can feel it, I don't know where it is. I can't see it. So what I then get him to do is to maintain a mirror image the whole time. So you maintain that in exactly the same way. Now, what I'm going to start to do is work with the real limb, obviously, because I can't work with the one that's not there. And I'm going to start just maneuvering it. Tiny movements, tiny. I want you to keep maintaining a mirror image. Just a little bit. And if it's locked in place, obviously, kinesthetically, recreate it to be exactly the same. And little movements, and then what I would do is, again, tiny. Do too much too soon, you'll get a disconnect from what he's able to do. Because he'll be able to make little movements in the phantom, just not realize it. As time goes on, thank you, if you just have a seat and put your arms in front of you, I will then start to increase the level of movement. So I'll start to progress, if you do it like that, for example, I'll start to progress from fingers to the wrists. Tiny movements, and then I'll start to get a little bit more, and so on, and essentially start guiding it round. If you're forcing it like this, you're going to get a counter resistance, and it's not going to work. It can take hours. So, pot of tea, lot of cake, put the air conditioning on, you're in for the long haul. If you break the session halfway, and supposing he's got it here, right, so he's now like this as opposed to like this, guess what's going to happen? If you break for too long, the phantom is going to start going back to its default position. So there's no point in doing this for 2 hours and then thinking, oh God, is it going another 2 hours? And then quitting. Right? If you're going to do this, you're in for the long haul. The officers that were present in this context, this situation, I don't think they were quite ready for it. And do you know what? They sat virtually to attention the whole time. They didn't break a sweat, and they didn't move. They didn't flinch the whole time. Total self-control and discipline. And then what we'll start to do is just get it into the approximate position where he can then create the illusion with the mirror. Thank you, Carl. So position and location is very, very significant, and is something that's really overlooked clinically because people don't think to ask. They just naturally assume you stick your hand in the mirror box and look at the reflection. They're not setting it up correctly to create the illusion to be convincing. Mobility of the phantom. A phantom that cannot move. I've not yet found one of those where a phantom that doesn't move, there won't be remapping. There won't be. I'll explain why in a second. You don't get any result with the mirror box. At least not that I found. It just simply doesn't work. There's something else we can do with regards to position and location. You know I said about drawing on the face where the thing is? I can manipulate the cheek because the location of the cheek, if I move my cheek across like that or like that, my brain knows it's been moved. The corresponding movement occurs in the phantom. So I can massage the relevant places in the neck, shoulder, and face in order to help reposition the phantom. If you've got somebody who's sufficiently trained to know what to do and doesn't try and do too much too soon, they can be manipulating the other arm while you manipulate the face, and then you can release the contracture and move the phantom into place. So you can accelerate the process. I think that would probably take a little bit of practice with the other person to coordinate it. It's a bit of a weird thing to do. It's not what people would normally do in a therapeutic clinical treatment type session. I have not yet done a genital manipulation on a client in order to reposition the phantom foot.
Did you want me to demo? No.
Not today. Not today. Maybe tomorrow. But we can start to find, you can start to see a way that you can start to get the client to be able to do it themselves. Maybe you want to leave the room while they do that, who knows? Or maybe they can do that, you can teach them how to do this when they're on their own, and they can use that accordingly. Massively, I say it's so overlooked. When I talk about this with clients, no matter how long they've been an amputee, I have found I'm consistently the only person that's ever discussed it with them. And I just find that extraordinary. It's disappointing at the same time. Now, where there is check for congruity between the image and the kinesthetic representation. If there's an incongruity, so yeah, it feels like it's contracted, but when I look at the phantom, it's in the correct position. That's an incongruity. Yeah, the phantom pain, it's like burning. It's like it's on fire, but when I see the phantom, it looks like a perfectly normal limb. There's an incongruity. That's more likely to suggest a physiological factor in the presence of the pain itself. And this is where it now starts to get really confusing when you're assessing people. You can have a person who's got something like a brachial plexus injury. So they have, usually it's a motorcyclist, they've held on, they've gone over the top and it's ripped the arm, and that rips the nerves in the armpit. Not a very nice experience. And the arm will be paralyzed. So they end up in a sling. There's not much use of the arm. Frequently that's then amputated because the limb is more of a nuisance to the person than it is benefit. Not always, but it just depends on the individual. You can have somebody who has a limb that's still attached and have phantom limb pain. The two things can exist at exactly the same time. Because in brachial plexus injury, you've lost sensory information to and fro the limb. You can now have a phantom that's there as well because the brain's going, hey, I'm over here, where is it? And a phantom can emerge. So you can have physical pain at the same time as well as having phantom pain. So you have a stump that has neuromas, because obviously the nerves are cut when they amputate. They have neuromas in there that are triggering pain to go up the nerve pathways, and the presence of a phantom at the same time. The phantom may not hurt, right? Not all phantoms are painful. It's not phantom limb pain isn't just phantoms. You have plenty of phantom limbs with no pain. But now this can be confusing because you have somebody with neuromas in the stump who has pain, and they talk about the behavior of the phantom, and it's assumed to be phantom limb pain. The mirror box is not going to help that patient. Okay, it's not, because it's a physical pain. Surgery will help that patient. You take off the neuromas or take off another inch of the stump. Bingo, wow, we've cured their phantom limb pain. No, we've cured their stump pain or their neuroma pain or the skin sensitivities that can emerge as well. Now what we tend to see is a huge overlap between the two. Clinically, this is what I tend to see. So we'll have people that have causes of physical pain and odd sensations because the big nerves have been cut, right? And things grow around those nerves. The nerve cells grow and attach to things. And we have the phantom and the phantom limb pain. There's going to be an overlap where both of those things can coexist. Sometimes people will just be here, sometimes people are just here. The majority of people are in the middle area. I've just done a recent assessment and treatment with an individual where he had remapping was there, the limb was mobile, the image of the limb and the representation of the limb kinesthetically matched. He was the perfect candidate for mirror box treatment. In using the mirror box, we had a tremendous result in working with him on everything except the pain, which sounds a bit weird if you think about it. I then, on the results of that, wrote to the treating physicians or the surgeons and notified them that I don't believe this man has phantom limb pain. We changed the phantom and everything else. What he has is neuroma pain. Subsequent surgery removed the neuromas. He's pain-free as a result. It becomes a bit of a grey, difficult area. Any questions on that bit? I'm going to show you. Can I borrow you? Yeah. Allow me to please demonstrate with this fine gentleman here.
Isn't there anyone?
Well, yes, it's a bonus actually. Otherwise, we'd be in a bit of an awkward. Right, are you aware of any remapping that's occurred for you?
No. So when you're saying pain, I mean my arm's still there. I can still touch it and feel it there.
Yeah.
It's, as for being up there or anywhere.
So yours is okay. So if we go through this.
Yeah, I can.
Okay, so if we just go through this, so we know that the position is logical.
Yep.
And the location is correct. Is the limb bigger or shorter than it's supposed to be? So it's quite correct. Does it move?
Yeah, if someone throws something to me, I'll go, oh, well, we'll go to catch.
Right.
Obviously it's not there.
And by the way, I've seen that done. A junior doctor in a unit that I was working on as a nurse, the person had a limb that was stuck. And he went catch and threw the ball at the person went to catch it, and the thing moved. Obviously, we don't see anything, but he said that's really weird. It's moved the limb. I wouldn't recommend doing that because you could actually offer a huge insult and demonstration of misunderstanding to the client. Is it normal, traumatized, or contracted? Normal, by the sound of it. Have you ever noticed any remapping phenomena? No.
No.
Okay. So what we know is all of this is looking good so far. We don't know if remapping has occurred. How long ago was your amputation?
2005.
So a few years ago.
But the brachial plexus was 32 years ago.
Wow. Okay. So the original injury was a long time back. All right. And did you have, before they amputated, were you aware of a phantom that was there?
Yeah.
Okay. So you have a limb and a phantom.
So I had pain there, and I just assumed it to be. The pain stayed the same, no matter whether I had the arm or I didn't have the arm.
Okay. And do you ever have movements where the phantom moves on its own, involuntarily?
Yeah, I have like stump twitches where it just, for no apparent reason, it'll just start twitching.
Yeah. Strange. Does it reach for things?
Yep. You can still go to push to open the door or something like that. You can't get that out of your mind. It's still constantly there.
Okay, close your eyes. All I'm going to do is touch you on the face with a Q-tip. It's clean, not used. And all I want you to do is just notice what you notice. Don't make anything happen. Don't force anything to be the way it is. Don't worry about the fact that, obviously I'm hoping there's remapping. That doesn't matter because we're looking at what is as opposed to what we hope for and what's supposed to be. That's really important. Nothing may happen at all. Who knows? I suspect you probably won't from what you've told me, but let's just see. So if I just... So what I'm doing is I'm just working all around the area. Basically, it's from the midline, and the whole area. Lips can be quite significant. Anything?
No, just the same normal buzz. No change in sort of where it was. It's just.
Okay, look. So what we're looking for here is, was there any sensation occurring in the phantom while I'm touching your
No,
face?
it wasn't changing. It's just a normal sort of pitch.
So from my position, this now demarcates where I'm going to go, likely to go with the mirror box. I'm going to give it a go anyway, because there's nothing to be lost by giving it a go. But I'm not sure whether it's likely to be effective. So I'm now be looking at other ways of working with the pain. And do you have pain?
Yeah.
What is the pain like?
On a good day, it's not a problem. But on a bad day, it feels like someone pushing swan vestas up your nails and striking
So
them.
it's
That's
wow.
how it feels. I've been that bad before, where my hair's dropped out, alopecia.
Yeah.
There's nothing that can stop it, and then just like that, it'll be gone. Which is weird.
Right. So what about at the moment?
At the moment, it's my normal burning sensation. It's livable.
Okay.
Just sort of put it in the back of your mind all the time.
Yeah.
Which I suppose just about everybody does. You just blank it out or try and blank it
Yeah.
out.
We have to. I mean, how else do you then go about your day? And okay. And have you had any neuromas or any other problems with the stump?
No.
Are there any? Let's just try this. Close your eyes again. What I'm going to do is I'm just going to go with the arm here.
You see, I've not got much sensation in the stump. It's patchy
Yeah.
all over the place.
Sure.
It's just tingling, basically.
Where?
It's shooting sensations up into my shoulder.
Okay, so you're getting a sensation up
Yeah,
there. Yeah.
but basically it's just sensation more than anything else.
Right.
Because there's not much feeling in different places. On the
Yeah,
stump.
yeah. But nothing's coming down
Nothing's
into
coming
the.
down, it's just like where you're touching, I can feel it sending little shooting pains.
Okay.
Well, not pains, but little sensations.
Does that answer your question? I can't remember what the question was.
Yes, and then when you touch them in the fingers, what you tell them when you're trying to get the mirror image to know where the limb is.
Right, now he's able to tell me that it's right in front of him. Now it's unlikely, here's the thing, his limb is very unlikely to be in a contracted place because he's got this portion of the limb left. If it was taken off at the shoulder, then it could well be in a illogical position. But here we know there's going to be some level of movement. Can you do this with the? So again, that's a fairly hopeful sign as well with that. Yeah, so you get an idea. The other illogical positions. I had a guy I've got film of. He's sitting on the floor, and when he sits, the leg is in a fixed position. Now it's gone here, but his leg is in that position. So when he sits on the floor, the phantom is actually going into the ground and through the floor, and he finds that a very, very peculiar experience. And when he stands up and is walking around, he literally feels like he's walking like that, except the weight element isn't there. So he'll put a prosthetic on, and he has to really pay attention to his prosthetic because his foot is actually sticking out the back. He was the guy that when we then set him up with a mirror box, starts freaking out. And in a way that I'm starting to think, oh, this may not be an outcome that we want to see. But actually afterwards he said, no, that was amazing. That was incredible. And yet on the video, he appears to be having the exact opposite kind of experience. Any other questions about anything on that? What is in there?
But regarding when you're going to touch the fingers, it might sound simple to you, but it's not.
Well, these fingers here.
Yeah, when you are trying to imagine or you can represent where the arm is,
Right.
that is missing, and we're just touching the healthy arm.
Right, just supposing his phantom's stuck out there, all right? So what I would do is get him to make a mirror image with this one.
So obviously, like,
Right.
put me on that there.
So just supposing, I mean, I've never seen a phantom that looks like this, but it just makes it easier to demonstrate. What I'm going to do is I'm going to start here.
So you're asking, yeah.
Yeah, tiny movements, all right? And what I want him to do is to maintain this to be an exact copy of that. So if that's rigid, right, in a contracture, then he must make this rigid too. And I'm just going to start introducing changes. Because he's making that a mirror image of that, simultaneously he's making that a mirror image of this. Now if I start doing this, it's not going to correspond. but little movements can. And all I'm now going to do is start to increase that level of movement over a long period of time. As he is able to move it more, I'll move it more.
Or do you talk to him when you do that?
Yeah, I can do.
So what do you say?
It depends if you like them or
How
not.
you start it? How do you start? I mean to move your finger, I mean to touch your finger. How do you start the process?
I'll just tell him to keep it the same, and don't...
Tell him. Tell him to
Yeah,
him.
I'll go, oh, keep it the same. I'm just going to move your fingers like that.
Yeah.
All right, don't make anything happen. Don't do anything to please me. This must form a mirror image of that. That's what I'm going to do. Thank you. Here's, I think, one of the things I would use as a guiding principle. Don't talk to him as you're a physician, he's a patient. Talk to him like he's a person and you're just a person talking to him. Talk in normal everyday words, in a normal tone of voice. My overriding thing as a therapist is I'm not terribly professional. Now, I don't have clients complain, but I would if I worked in a hospital or in a clinic, because my manner and my tone isn't entirely professional. I talk like a normal person to a normal person. And that's what I recommend you do. Because otherwise, what starts to happen is patients will start to leave the responsibility for the experience to you, because you're the authoritative doctor. I mean, you know, as a doctor, you tell a patient to strip, they'll strip. Tell them to stand on one leg and they'll do it. Because the white coat thing, they'll do whatever you tell them to do. It's just very odd. If I have an injury and I bring it to a doctor that requires surgery, I'm not involved in the process. I'm entirely passive. I do as I'm told. You do all the work, you put me asleep, you do the operation, you wake me up, everything's fine. I don't have to take any responsibility for anything. That's not the experience we're creating here. And after lunch, I'll be taking you through what we do with the mirror box. So I tend to drop all the status as much as possible. And in part, it's why I've adopted this kind of thing as well. Because by presenting people with a medical-looking device, they might be waiting for the device to cure them. They might be waiting for, like people wait for the pills to take effect. They will treat this as in the same way they treat a medical intervention, which is one with entire passivity. So that's what I'm really keen to avoid. And I've never had anyone object. I've had clinicians object, to me mostly, but I've never had, that I can think of, too many, well, I can't think of any patients that object to my manner. Okay, maybe two. Hang on, there was that one. Three, okay, I can think of a few, but it's not the norm. I thought you were. No. Any other questions?
I have brachial plexus complete avulsion. I still have my arm, but I have no ability to move my arm in my head. For example, I slipped over at the top of the stairs.
Can we swap places?
Yeah.
Is that all right?
Yeah.
You don't mind?
Thank you.
So 'cause all this is useful information to have as well, you see. It's a bit different now, isn't it? Oh, yeah. Just don't look at them, we'll be fine.
I'm not going to.
Yeah.
But I have no reaction ability. So, for example, he said that if somebody throws a ball or whatever, he would go to catch it. I don't have that. I slipped over at the top of the stairs and I had no ability, thought, reaction to put this arm out to save me. Nothing happened. It just was flail
Right. Yes.
and stayed flail.
Yeah.
This hand, I put out to save me.
Okay. Do you have sensation?
No, none.
None at all. So
No. It's completely paralysed.
so if you didn't see it, you don't know where it is, unless it is touching the body.
Yes. No, I don't know where it is. And in fact, the other night I woke up and my arm had slipped out of the bed, and my hand, it gets cold.
Yes.
Colder, quicker. Yeah. So I'm very sort of vigilant with it. But interestingly, I woke up the other night and it was out of the bed and it was cold. And I had no idea it was out of the bed until I opened my eyes and saw that it was out of the bed. So there is no sensation, except, of course, the weight of my arm up here, because I have sensation here. But I'm just interested, that because I was talking to my partner and saying, if I shut my eyes and try to imagine moving my hand, I can't. It doesn't it doesn't move.
Close your eyes. Don't try and move the hand. Describe what you see.
Well, I see that it's in a sling and in front of me, because that's kind of where it is, and I'm a bit too literal, I suppose.
Okay, now if I were to I'm not going to do this, but if I were to keep your eyes closed, and I was then to put something in front of you we could rest your arm on, and I put it in a position that you're not aware of,
Yeah.
what would you see? If you take a look at the limb, what do you see?
I see it out like that. Like that. I think.
And is that just kind of like an imagination, or is that like a real experience?
No, that's an imagination.
Okay.
I can't.
Right, so there's no phantom
struggle
here.
to visualise
Right.
it
Sure.
anywhere, really. I maybe that's just because I'm so literal. Like,
Yeah.
I know it's there in that position, and so therefore it is in that position.
So essentially what we've got, you can open your eyes, you don't have a phantom limb.
No, but I have pain.
Right.
Chronic, excruciating
Where is the pain?
in my arm.
In the physical arm?
Yes. Burning, pressing. It's like somebody giving me a permanent Chinese burn.
And I'm guessing that's not relieved by any massage or manipulation of the limb.
No, I mean, you do. I find myself touching my arm all the time, mainly because I'm sort of moving it a little bit because of that whole thing of that, which frightens the life out of me. That eventually I'm going to become disfigured, if you like, to that extent. Already there is a huge amount of wastage in my hand. You know, the muscles have gone in my palm. So I'm constantly kind of manipulating it. And so you do tend to find different bits that you might put your hand on that release it for a moment or two, and then the moment's gone. So I have what is called peripheral nerve pain.
Yes.
All the time, except for when I'm asleep and then when it wakes me up.
Okay. Now, there's a strange thing, and I'm not fully understanding as to why this works, but for some limb pain conditions, chronic regional pain syndrome is one of those. Complex regional pain syndrome. The mirror box technique tends to work quite well for that. I've got no first-hand experience of that at all. This is something from clinicians I know that specialise in that area. They report very good results. What we have here, this is not a phantom. Very clearly, you have pain in the limb that you're experiencing. This isn't an exclusion for using the mirror box. Now, for reasons I don't know, so we'll, if you like, we can give it a go this afternoon after lunch and see what happens.
I have dabbled a little. One particular time I was up at Stanmore Hospital for a week of rehabilitation for my new condition, and they gave me a box, you know, one of the ones you buy off the internet, and one of the ladies that was on the ward with me asked me what it was, and I explained what it was, and I sort of showed her what the process was and the thought behind it and how it worked, etc., etc. And I sat with this arm in the box and doing the reflection thing for about 25 minutes, just chatting to her, but glancing, and the pain went.
Right.
It was amazing. Another time, more recently, I tried to use it. I've only really done it 3 times. I tried to use it, and it didn't work. And I don't know why. I don't know what was different, but something was different, and it didn't work. And then one other time I used it at home, and it did work, and was great. But it doesn't and hasn't.
Doesn't
lingered.
last. Yeah. So it gives temporary relief, but it doesn't last for long.
Which is wonderful.
Yes.
And even for those few minutes, it's kind of worth it. But I kind of know that I need to retrain my brain to have that anaesthetic all the time. So that's kind of
Okay, we'll experiment with that this afternoon and look at what is the difference between when it works and when it doesn't work. I have a suspicion I know.
Oh, okay.
At least I hope I do. We'll find out actually
Okay.
this afternoon.